Organic acidemias. The overview of the lecture, it will include a brief introduction, and then we are going to discuss the common organic acidurias which are encountered in the pediatric ICU as well as in the neonatal ICU. So what are organic acidemias? Organic acidemias or organic acidurias are a group of inherited disorders. So organic acidemias or organic acidurias are a group of inherited disorders. All of them are inherited mostly on an autosomal recessive basis, and they result from a defect in the catabolic pathway, enzymatic deficiency in the catabolic pathway of the amino acids. Taban, if we have a look on this slide, it will look very complicated. Okay, but let us focus on the three main amino acids: the branched chain amino acid, the leucine, the isoleucine, as well as the valine. We are going to see that in the pathway, in the catabolic pathway of valine and isoleucine, at the end we will have propionic acidemia and methylmalonic acidemia. On the other hand, in the catabolic pathway of leucine, we are going to find isovaleric acidemia, 3-methyl-glutagonic aciduria, and 3-hydroxy-methyl-glutagonic aciduria, glutaric aciduria. So as we have mentioned, that most of the organic acid result from an enzymatic deficiency in the catabolic pathway of amino acids. Most of these organic acidemias become clinically apparent, as we have discussed in the last lecture, in the newborn period or in early infancy. And they are on the top of the list of this disease, presenting with an acute metabolic emergency in the ICU. So we have to have a great awareness about these disorders. And as we have also discussed before, usually the baby or the newborn is delivered, and there is an initial period of well-being. After this initial period of well-being, and with the introduction of milk and protein, there will be gradual formation of the toxic substance, and this would result into metabolic acidosis with an increased anion gap. This presenting episode may be misdiagnosed or mistaken for sepsis, and if unrecognized, is associated with significant mortality and morbidity. And all of you know this, we have discussed this before. Children with organic acidemia are very susceptible to metabolic decompensation, especially if they are stressed. Like, for example, they have a febrile illness, or they have a gastroenteritis, or surgery, or any of the stressful situation. Therefore, both parent and physician, should be aware very much of this condition in order to be able to deal with. So the aim of this lecture is to empower you how to have an early recognition of this disorder, and at the same time, how to be able to treat them promptly, even if you don't have the final diagnosis. Even if you diagnose that this is a patient who is having an organic acidemia, but you don't know whether this is a methylmalonic or propionic, etc. Even if the definitive diagnosis is not there. The diagnosis of all these organic acidemias is performed, of course, through an extended metabolic screen, which appear an abnormality in the acyl carnitine profile, and this should be confirmed by urine organic acid profile done through gas chromatography mass spectrometry. We have here, the gas chromatography mass spectrometry, and we have also the extended metabolic screen, اللي هو LCMS-MS. Prenatal diagnosis is available for most of these disorders. زمان كانوا بيعملوا prenatal diagnosis through either detection of diagnostic compounds through amniocentesis, amniotic fluid, or through analysis of the enzyme activity, but all this can lead to false results. And therefore, we do depend now on molecular diagnosis. And therefore, it is very important. Then when we diagnose a proband, مش بس أقول إن هو عنده methylmalonic or propionic acidemia, I have to go further and to characterize the molecular the genetic background أعرف الجين المسبب and this is for the future pregnancy so that I can help the mother during if she is going to do a prenatal diagnosis for this condition. And of course, the best way to diagnose this patient is through newborn screening. للأسف احنا لحد دلوقتي في مصر احنا عندنا 2.5 مليون مليون مولود بيتولدوا سنويا بس we cannot due to financial issue we cannot do the metabolic screen اللي هو including 19 or more of the treatable inborn error of metabolism. Now عن طريق وزارة الصحة we can do only for those يعني موجودين في الاي سي يو اللي هم دخلوا الاي سي يو او النيكيو مش اي اي سي يو حتى النيكيو اللي هم زي ار ال هم دول اللي بياخدوا منهم العينات واللي بيعملوا لهم السكرين. Otherwise there is no screen. We screen only for hypothyroidism and for phenylketonuria. وانا صراحه كان عندي اقتراح ان واي نوت ان احنا يتقال للناس لان السكريننج ده ما بيكلفش 250 او 300 جنيه بالكتير. نقول للناس احنا هنعمل لكم الفينالكيتونوريا والهايبوثايروديزم ده من غير فلوس على حساب الدوله، لكن اللي عايز يعمل an extended metabolic screen he has to pay for it and I think that a lot of people can pay for this 200 or 300 جنيه which is nothing now in order to know if their baby are harboring any of the treatable metabolic disorders. The mode of inheritance, as you know, it's an autosomal recessive mode of inheritance. نعم. أيوة كل نيوبورن.
هو جاب طفل قبل كده في يعني suspicious.
لو جاب طفل قبل كده المفروض ان هو يتشخص what kind of metabolic disorder ويتعمل له كمان الجين عشان لو الام عايزه تعمل prenatal diagnosis يبقى it's better not to be done through لا اما amniocentesis. هل في ميه؟ ممكن ميه؟ لا يعني بدل ما يتعمل عن طريق enzyme analysis او يتعمل عن طريق الموليكولر وده اللي احنا بنعمله حاليا يعني. Most of the conditions are inherited on autosomal recessive basis. Very few are inherited on an X-linked basis. They Barth syndrome associated with cardiomyopathy and neutropenia. Organic acidemias are actually classified into two big categories. What we call classical organic acidemia or classic organic acidemia, and the other is cerebral organic acidemia. The hallmark of classic organic acidemia is a metabolic acidosis with an increased anion gap. So, مفروض in this classic organic acidemia does not pose a great challenge in its diagnosis. But what poses a great challenge in the diagnosis is the cerebral organic acidemia because they present with a neurodegenerative disorder or with spastic paraplegia. Sometimes they can present with cardiomyopathy. Yani they have an unusual clinical presentation and this makes their diagnosis actually very challenging. A common presentation of classic organic acidemia, and this is what we are going to discuss today, the classic organic acidemia. As you know, whenever the patient has building up of toxic substance, he is going to become lethargic, anorexic, vomiting is an obvious part of the presentation. He will become dehydrated and then hypotonic due to lack of energy, and the mental status will be altered and he can come to you comatose. The key laboratory findings include the most important is a severe metabolic acidosis associated with an increased anion gap, sodium minus chloride and bicarbonate. If sometimes you said that we don't have chloride, ما عندناش chloride ما بيتعملش في المعمل. Consider the patient as if the patient is coming with severe metabolic acidosis, consider him as if he has an increased anion gap. Okay, we are going to act as if he has an increased anion gap, and we have to consider him as possible organic acidemia. Of course, this is associated with ketoacidosis. This is easy ان انا احط keto steps in urine واعرف لو كان عندي كيتون باضت ولا لا. Hyperammonemia, lactic acidosis may be present or may not be present, And of course, the diagnostic is through performing a urine organic acid profile by means of the gas chromatography. We will discuss today, inshallah, glutaric aciduria type 1, and methylmalonic propionic acidemia, both of them are discussed together, and then the holocarboxylase deficiency, Muppet syrup urine disease, and isovaleric acidemia. The discussion will be through case presentation. I have started with glutaric aciduria. Why? Because glutaric aciduria actually have several presentations, and it is considered one of the non-classical organic acidemia because it does not present with an overt metabolic acidosis. يعني glutaric aciduria من ضمن الحاجات اللي أنا present today does not present with an overt metabolic acidosis with an increased anion gap. No, it have different presentation, and now we will go through these different presentation one by one. First of all, it can present with an encephalitis-like illness. And let's see together this case. This is a 12-year-old male patient, first child of first-degree cousin, who was brought in with the chief complaint of developmental delay and intellectual disability. Yani we saw this patient at the age of 12 years with global developmental delay and intellectual disability. He was a full-term baby, uncomplicated delivery, and an eventful perinatal history with normal development till the age of 2.5 years. And this will teach you not every inborn error of metabolism come in the first few months or in the first few hours after birth. No, they can present later in life, like at 2, at 3, at 8, and you will see this through the lecture. At the age of 2.5 years, he presented with disturbed level of sensorium, convulsion. He was admitted to the Pediatric ICU for 10 days. CSF analysis was done, and it was interpreted as CNS infection. It was interpreted, and I doubt, because a lot of patients come with an encephalitis-like picture, okay, and we perform CSF. This is usual scenario what happened. And when the CSF is free, we don't find cells, we don't find protein, etc., we say, yes, okay, this is an encephalitis, but it is a viral encephalitis. And we give the patient Zovirax, etc., and the patient is discharged. Actually, he is discharged and diagnosed. Okay, so this is very important. If you suspect encephalitis, you perform CSF, and the CSF is free, then don't say that this patient has an encephalitis or a meningoencephalitis. You have to search for another etiology for the encephalopathic period the patient is suffering from. He received treatment, conventional, in the form of IV antibiotic, and then discharged, as the mother said, completely normal. 3 months later, he developed another attack of convulsion and disturbance in the level of consciousness, for which he has been admitted again. And again, he started, and again, most probably he was suspected as another attack of encephalitis. And then, but after this period, he started losing some of the previously acquired milestone of development. And as you see, the patient looked a little bit dysmorphic. He was microcephalic, actually not macrocephalic, and he had synophysis and an elfin facies or an oval facies like those of fragile X chromosome. And this was our first clinical impression that this patient may have a genetic mental retardation. Microcephaly, protruded ear, elongated facies, but normal muscle tone and reflexes, no organomegaly, and he had severe hyperactivity. This is the MRI of the patient, and I want you to look to this MRI, the T1 weighted MRI, looking at this frontotemporal atrophy with the Sylvian fissure wide and H-shaped Sylvian fissure. Because this picture, we are going to see it in several patients with glutaric aciduria. We cannot say that it is pathognomonic, but once you see this, you have to suspect immediately glutaric aciduria. This is not normal. This, okay. الواحد لازم ما يتحركش. اوكي this so اول ما اوكي So this was a male patient with mental retardation, severe hyperirritability, and aggressive behavior. He lost his previously acquired milestone after an attack of encephalitis, microcephalic with some dysmorphic facial feature, and the brain, he had a brain atrophic changes and area of encephalomalacia. His basic lab were normal. He did not have metabolic acidosis and normal lactate and ammonia. But this was not all. What triggered us to think about this patient as having a metabolic disorder? This is coming. Okay, he had a young sister who is 1.5 years old and who was previously normal until the age of 1.5 years, when also she got an attack of encephalitis-like picture, of encephalopathy or encephalitis-like picture, again, because we don't take proper history from the patient, from our patient. We only take a very rapid history. Taking a proper history is very, very important because it can give us sparkle كده to think about what is going on. فدي second child مش معقول كلهم they have encephalitis and probably at the same age, etc. There should be something else underlying these episodes. His sister, as you see, had a little bit like relative macrocephaly. Her weight height were under 50 centile. She did not have dysmorphic facial feature, also no organomegaly and no muscle tone. Okay, her basic laboratory investigation also all were normal. CSF even was normal, and the patient again was treated as a case of viral encephalitis. And this is again her brain MRI. As you see, it's typical like her brother with the H-shaped Sylvian fissure and the frontotemporal atrophy. This is the family pedigree of the patient. Demonstrated that both parents were consanguineous parents, and they had 5 children. 2 of them were affected, and 3 of them apparently were normal, going to school, and they have a normal intellectual intellect. So our differential diagnosis was the following. Is this patient was suffering from a post-encephalitic sequelae, if he had a possible inborn error of metabolism, or he had a genetic mental retardation due to its dysmorphic facial feature. Once you encounter any patient with global developmental delay, automatically you have to screen this patient for an extended metabolic screen and a urine organic acid profile. Okay, this is what we have done. His amino acid profile was normal, but his acyl carnitine profile demonstrated that the carnitine was very low, was consumed, and his glutarate carnitine was borderline elevated. What confirmed the diagnosis is performing a urine organic acid profile, which showed that he has massive excretion of glutaric acid and 3-hydroxyglutaric acid. And so this patient was diagnosed as glutaric aciduria type 1. And then once you diagnose a proband in the family, whole family should be screened for. And this is what we have done. The 3 remaining siblings were screened for organic aciduria. And we found that 2 out of the 3, the girl 10 years old and the boy who is 9 years old, they were completely normal. They were at school, nothing, no previous metabolic crisis, but they were asymptomatic carrier of the of glutaric aciduria. We start them immediately on L-carnitine and riboflavin and a low protein diet, even if they are asymptomatic. And this is the importance of doing a screen or what we call Cairo screening for any any patient in a family in whom you found a proband affected, all the SIB of the family should be screened for, and even يعني لو كان في أطفال آخرين in relation to them, they should also be screened. This is another case with glutaric aciduria. As you see, this is typical patient presenting with macrocephaly. He was presenting with this dystonic, episotonic dystonia because he had here, look at the brain MRI. This is a T2 weighted brain MRI. Also, again, the wide Sylvian fissure, the H-shaped Sylvian fissure. But look here at the basal ganglia. We are going to find that here the putamen and the globus pallidus on both sides are affected. There is high signal intensity in the basal ganglia. And this is what we need to prevent. Once the patient had a stroke in the basal ganglia, then this patient will go into dystonia and into abnormal movement. And once this happens, the prognosis is not that good because it is very difficult. Dystonia من أصعب الحاجات اللي احنا ممكن نعالجها. Whenever you give treatment for the dystonia, they are motor بيفضلوا على طول having a motor handicap. And therefore the prevention is very very important. وعشان كده بنقول لو في newborn screening ونقدر ان احنا نشخص الجلوتاريك اسيدوريا دي since day 1 or day 2, and then we will prevent those patients once they are early diagnosed, they go without any metabolic crisis and they have a very good intellectual ability. So this is very important. But once we got a stroke in the basal ganglia and the patient got dystonia, it's very difficult to reverse this. Very difficult. Even if you give the treatment, even if you give the restricted protein diet. Okay. Another glutaric aciduria, another presentation. So we saw the presentation of glutaric aciduria presenting as encephalopathy or encephalitis-like picture. Another patient can present with dystonia. And this patient had no clinical, she presented to us in the Neurometabolic Clinic at the age of 6 months. And she did not have any clinical symptom at birth. She had a normal development until the age of 3 months. At the age of 3 months, she started to manifest gradual and progressive dystonia without encephalopathy, and without an overt encephalopathy, without metabolic acidosis, with nothing. And presenting to us at the age of 6 months with macrocephaly, severe dystonia, as you see, so she was severely dystonic, global developmental delay, and no metabolic acidosis. And this is her, again, the brain MRI demonstrating this wide-shaped Sylvian fissure. So any patient presenting with dystonia, the diagnosis of cerebral palsy should be done after exclusion, ya jama'a. Don't label the patient that he has an ischemic hypoxic encephalopathy because he is presenting with spastic paraplegia or he is presenting with dystonia. We have diagnosed a series of patients with organic acidemia, and they were presenting with spastic paraplegia and they were presenting with dystonia. So it's very important to let this ischemic hypoxic lasting after بعد ما يعني نعمل all the possible diagnostic tests, and then we can say that this is cerebral palsy. Another form of glutaric aciduria, it can present with a subdural hemorrhage. If you look to this MRI, here, this is a T1 and this is T2, and looking to this crescent shape abnormality, this is a subdural hemorrhage. And at the same time, we have here this widened Sylvian fissure again. So subdural hemorrhage can occur at any time in patient with glutaric aciduria. With a maximal extent of macrocephaly. This is what occurred from 3 months to 36 months. This patient can develop this subarachnoid hemorrhage after a minor trauma. يعني واحنا بنلعب مع الاطفال وبنرفعهم هكذا ممكن يحصل لهم this minor trauma because the veins are stretched between the skull and between the brain, so they can be easily ruptured, and then subdural hemorrhage can occur. So glutaric aciduria should be excluded in children with suspected chicken baby syndrome using the recommendation for selective screening. And another point also is sometimes when you do your brain MRI or your CT, and then the radiologist comment that the patient has a bitemporal arachnoid cyst. Please take this also in consideration. If the diagnosis of the radiologist is bitemporal arachnoid cyst, no, you have to let this patient do extended metabolic screen and urine organic acid profile because this patient might have a glutaric aciduria. Okay, يبقى bitemporal arachnoid cyst, subdural hemorrhage when there is no other reason, يعني ما فيش حاجه واضحه تؤدي الى انه يحصل له the subarachnoid hemorrhage, and then we have to screen this patient for organic aciduria. Another case, and I saw this case in my private clinic, which the patient was coming only with microcephaly without any neurological manifestation. She was a 5-month-old female patient and was referred for evaluation because of macrocephaly, not associated with any other neurological complaint. Clinical examination, only macrocephaly. Her head circumference was 49 centimeter at the age of 5 months, which was above the 97 centile for age. She had a good head support, smiling, a social smile, etc., responding to auditory stimuli. Again, أعتقد إن صورة البرين MRI of glutaric aciduria now have been printed in your mind, that whenever you are going to see a brain MRI or CT like this, أول وهلة you will think about glutaric aciduria. And then, and this was the CT of the patient, okay? Of course, when I saw the CT, I put the first diagnosis that the patient has organic glutaric aciduria, and urine organic acid profile did reveal a significant amount of 3-hydroxyglutaric aciduria and glutagonic acid, the key marker of glutaric aciduria. And then this patient was immediately treated, and whenever we suspect, start treatment by L-carnitine, by riboflavin, and by little protein restriction pending the result of the investigation. Because sometimes urine organic acid it takes about 15 days, for example, or 10 days, and you never know if the patient is going to have an infection, a catabolic stress during this condition. So start, you will not harm the patient. Start pending the result of the investigation, and then when you have a confirmed diagnosis, we will put her on the proper dietary management of glutaric aciduria. And then she has been followed, this patient, I followed this patient for 2 complete years in the Neurometabolic Clinic, and she never got an encephalopathic crisis, and she was okay intellectually and motor-wise. So this proved the importance of an early diagnosis. والحقيقة الدكتور اللي هو عمل لي ريفيرال للكيس يعني I respect him very much. Why? Because when he found that there is something odd, or مجرد ان هو لقى in the head circumference is there is an absolute macrocephaly, he sent it for further evaluation. He did not say, okay, no, this is normal, or since the patient has a normal neurological, no. And this indicates that a simple measurement, like measurement of the head circumference, should be done as routine. It is very simple. But when you see that the patient is deviating, either macrocephaly or microcephaly, so you have to suspect that this patient has a neurological problem, and we have to dig deep to know what is this neurological problem. So, as I said, that macrocephaly with a relative or absolute should alert the physician, of course, to the possibility of glutaric aciduria, and that the routine measurement of the head circumference is very important. Another case also, this case I saw her in my private clinic, and this was a 2-year-old male presenting with global developmental delay and abnormal movement. At the age of 1 year, the patient got fever and encephalopathy, and again he was diagnosed as viral encephalitis. اظن النهارده هتطلعوا تعرفوا ان we should be very حذرين يعني very cautious before the diagnosis of viral encephalitis, especially if the CSF is free and okay. Examination revealed that the patient has is macrocephalic. He had severe dystonia. يعني he was clinically that patient of glutaric aciduria actually, and this is the MRI of the patient. As you see, there is the atrophic brain change. Here the Sylvian fissure is not very very obvious, but you will find that both the basal ganglia, there is a high signal intensity in the globus pallidi and in the putamen bilaterally, as well as in the caudate nucleus. Okay. Of course, I sent this patient immediately to perform an extended and urine organic acid, and the result was normal. Okay, the result was normal. So the patient was not diagnosed. Second differential diagnosis was the possibility of a mitochondrial disorder, because whenever you see a basal ganglia affection in the MRI, two major big entities should be put in differential diagnosis: either mitochondrial disorder or organic acid disorder. Okay, so I said maybe this patient is suffering from biotin responsive, for example, striatal necrosis or something like this. Anyway, I sent him to perform a whole exome sequencing, and the whole exome sequencing diagnosed that we have a pathogenic mutation in the glutaric CoA dehydrogenase gene. So the patient was diagnosed as glutaric aciduria. But of course, this patient was late in the diagnosis. He had a bilateral striatal necrosis and he had severe dystonia. So what is glutaric aciduria? Glutaric aciduria is an autosomal recessive disorder. The two offending amino acid, isoleucine and the tryptophan, they are converted into glutaryl CoA, and then are converted into glutathione CoA. If I have the glutaryl CoA dehydrogenase defect, and then glutaryl CoA will accumulate. This glutaryl CoA will be converted into glutaric acid, 3-hydroxyglutaric acid, and glutaryl carnitine, which can be detected in the LC-MS and by gas chromatography mass spectrometry. And this is again just to demonstrate what we have said, that okay. So in order to conclude with glutaric aciduria, after this we are going to discuss methylmalonic acidemia. So glutaric aciduria, she has several presentations. حد فيكم يقول لي what are the presentation of glutaric aciduria اللي احنا مرينا بيهم؟ اشوف how much. Yes. Encephalitis like picture. Yes. What? Dystonia, yes. What?
Global developmental delay.
Yes, global development. It could present with global developmental delay with abnormal movement. It could present only with macrocephaly, and it could present as subdural hemorrhage. Okay, as chicken baby syndrome. Okay. Yes, our patient can microcephalic. This patient, don't forget that this patient has been diagnosed at the age of 12 years, and he was going through this and diagnosed with 2 attacks of encephalopathy. And وبعدين يا جماعه كمان في نقطه مهمه جدا. If the patient come once with encephalopathy or encephalitis like picture and diagnosed as encephalitis, and come after 3 months or even 1 year with the same attack, you should have raised the suspicion. يعني anything which is episodic, you have to think about being a metabolic disorder. Okay? Yes. لا مش سامعه. his sister كانت macrocephalic. Yes, او اتليست كانت الهيد سيركمفرنس بتاعها كان 50 سنتايل فور ايج. هو ليه بقى؟ عشان مع النمو بتاعه حصل سيفير اتروفيك برين تشينجز. اوكي، هو ده اللي خلاه يبدو ان هو مايكروسيفاليك. I mean and I saw على فكره حالات جلوتاريك اسيدوريا they were not macrocephaly. يعني في ثوابت في الطب بس في a lot of diversity. اوكي، and كله depend upon our awareness and our high degree of suspicion.
طب يا دكتور، انا دلوقتي العيان بتاع الجلوتاريك اسيدوريا بيجي بانفلايتس تايب.
اوكي،
الكيس بقى ان هو اكشلي كان عنده انفلايتس مش ماسكول فايرال او بكتيريا انفلايتس.
اوكي،
بس هو كان جلوتاريك اسيدوريا.
اوكي،
يعدي مني اول اتاك.
اوكي. يعني انت عملتي سي اس اف ولقيتي سي اس اف في something suspected of okay, it could happen. It could happen that this patient, because these patients are like any normal child, they can have an attack of infection and at the same time having okay. اوكي،
هل اسهل مثلا دلوقتي لازم يبقى عندي هاي ليفل سسبشن في اي عيان يجي انفلايتس؟
at least والله this is very good ان احنا يكون عندنا high level of suspicion, why not؟ وبعدين if I will perform مثلا organic acid للعيان او an extended metabolic screen، اوكي، والاكستندد metabolic screen showed me او was negative it was، يعني هيبقى في صالح العيان. اني شك لا اتليست انت هتعملي عيان سي تي برين ام ار اي، هيبقى في عندك اي يعني هيبقى في عندك اي pointing in the possibility of metabolic، يعني encephalitis and then you, thank you so much. يعني encephalitis and then you perform a CT even or a brain MRI, you found this wide Sylvian fissure or you found basal ganglia affection، يبقى this is not encephalitis. encephalitis عمرها ما بتيجي basal ganglia affection ولا بتيجي this wide Sylvian fissure. So you have to suspect. ما برضو ربنا سبحانه وتعالى بيدينا certain criteria in order to be able to diagnose the patient. And so our protein pool is derived from two major sources. The first source is the protein we eat, and the second is our muscle. If we don't eat protein, then our muscle will have breakdown. We are going to have breakdown of the muscle in order to supply our pool of protein, which are converted into amino acids. And then this amino acid is from this big pool of amino acid, we have two offending amino acid in case of glutaric aciduria. We have the tryptophan and we have the lysine, which require the glutaryl-CoA dehydrogenase in order to break down the glutaryl-CoA. If the glutaryl-CoA dehydrogenase is not present, okay, and then the glutaric acid is going to accumulate and it will build up to toxic level and give us the clinical picture we are seeing in the patient. If the patient is left untreated, he will develop gradual progressive neurological sequelae. Okay? Following an acute encephalopathic crisis. يعني usually زي ما الدكتورة كانت بتسألني if I miss the patient for the first one, if you are going to miss the patient, but if you are following up your patient, you are going to find usually after an attack of encephalitis, the patient start to regain يعني progressively يعني he start to improve gradual and progressive improvement. Okay, if he is not improving, on the contrary he is deteriorating, then you have to suspect that you have a wrong diagnosis. Okay, the main البوينت اللي انا احب اركز عليها ان يا ريت ان احنا we can diagnose and treat our patient before striatal necrosis, before stroke of the basal ganglia. لان زي ما قلنا once we have a stroke of the basal ganglia we will have dystonia and this will result into severe motor handicap and intellectual also handicap for the patient. The mainstay of treatment of glutaric aciduria depend upon dietary management. So we give a specific formula for the patient. This specific formula is devoid of lysine and tryptophan. Okay, اللي بنسميها X-lysine maximate. And this formula is present here in our Neurometabolic Clinic. It's present, of course, in the Metabolic Center at Ain Shams University, and it's present in different centers تبع the Ministry of Health. Okay? So this diet restriction is very important because it will provide the patient with essential amino acid, but lacking the offending amino acid that we cannot catabolize. ألا وهم الليسين and the tryptophan. But of course, this patient also should have normal protein in specific ratio between the specific formula and the natural protein in order to provide him for the lacking amino acids. Riboflavin, we can give our patient riboflavin, but there is a debate about riboflavin. Yani, some papers said that riboflavin may be beneficial, others said that riboflavin does not alter the clinical course of the disease. But we gave our patient riboflavin, B2. And at the same time, L-carnitine. L-carnitine is the mainstay of treatment in case of most of the organic acidemia. Why? Because it combines with the glutaril moiety and they form a soluble compound. And this soluble compound can be excreted through the urine easily. And therefore, the level of this toxic compound decrease gradually while using L-carnitine. You never stop L-carnitine in patients having any form of organic acidemia. Okay, so okay. أنا بس عشان all this statement نعم. Yes, الأكل بتاعهم you give protein no more than 1 gram protein per kg, natural protein. Okay, and then you بيبقى فيه specific يعني specific زي منيو موجود فيها مثلا البطاطسايه فيها how much protein, the potatoes, the bread, etc. and he has to accumulate to يعني accumulate this gram of protein بحيث ان هو ما يتخطاش حد معين من البروتين الناتشورال بروتين انتيك. يعني برضه هيعيش على بروتين ريستريكشن حتى لو ما بياخدش اللبن، لان في ناس بيقولوا after 6 years no need to give the specific formula. But he has to be on a restricted protein diet because you never know when striatal necrosis or striatal stroke can occur. So we have to be very judicious. Okay. In conclusion, any patient presenting with an encephalitis-like illness should undergo a metabolic workup. Okay, treatment should be started without any delay, even if the results are still pending, to prevent irreversible brain damage. Neonatal screening طبعا of organic aciduria is of utmost importance. بره الناس ابتدوا this screening من سنة 1960. So we are late by 60 years now ومش عارفين even when we are going to start this metabolic screening. Another important point, you have to take home message that whenever you diagnose a proband, you have to selective screen all the family member for the same disorder. And if you don't find, if the urine organic acid is normal and the extended metabolic screen is normal and your patient is not diagnosed, please go to whole exome sequencing to genetic diagnosis. Now the genetic diagnosis has been incorporated inside the clinical work. It is a part زي ما بنعمل CBC دلوقتي بقينا بنطلب exome sequencing in order to diagnose the patient. And a lot of patients على فكرة turn out to have treatable metabolic disorders. يعني I got through many patients. This patient were presenting with motor weakness. And then they motor weakness and speech delay, etc. And they turn out to be L-DOPA responsive dystonia. And they responded in a magic way to L-DOPA, to dopamine. And بعد ما الطفل ما كانش بيقدر يمشي ولا يتكلم بقى بيمشي ويتكلم and mentality near normal mentality. We have to make every effort to diagnose our patient properly. الدكتور معناه diagnosis. If we don't diagnose our patient properly, so we did not do our job properly. This is very important. Okay. And this picture, I like this picture very much because this is a program اللي احنا عملناه. كانت دكتوره سوسن، دكتوره فايزه رحمها الله، دكتوره عزه رحمها الله. We were all a group which اللي احنا اسسنا وحده الميتابوليك، الفيرست جروب اللي اسس وحده الميتابوليك في مستشفى ابو الريش. And this is a group of من الكلينيكال باثولوجي ديبارتمنت، منهم الدكتوره جينا، الدكتوره جينا this one because she was one، كان ساعتها مدرس مساعد وكانت من اوائل الناس اللي اشتغلوا معانا في المعمل الميتابوليك، والدكتور محمد عبد المنعم. اوكي next في حد عنده اي سؤال في الجلوتاريك اسيدوريا before shifting to the next okay I think it's quite clear. okay انا اليوم الوحيد النهارده ما جبتش نظاره، ما كنتش عارفه ان انا هطلع من البتاع الصغير ده. ممكن اكبره اهو. اوكي. So an 8-year-old girl brought to the ER with the chief complaint of seizures and altered conscious level. She was a result of full-term pregnancy and eventful. She was only observed to be slower in acquisition of her motor developmental milestone. There was nothing overt. But she did not have cognitive decline because she was in the second grade. كانت في سنة تانية ابتدائي وقت ما شفناها. At 8 years of age, the patient presented with altered conscious level, spasticity, and pathological reflexes. Laboratory investigation revealed neutropenia, blood gases, mild metabolic acidosis, but her brain MRI demonstrated, as you see, bilateral and symmetrical high signal intensity lesion in the globus pallidus, bilaterally in the globus pallidus. And this is very pathognomonic, pathognomonic for methylmalonic acidemia and propionic acidemia, especially methylmalonic. We saw a lot of cases of methylmalonic. Propionic acidemia is not that يعني much في مصر، هي أكتر في السعودية. But in methylmalonic acidemia, once you see this bilateral and symmetrical high signal intensity lesion in a patient coming with metabolic acidosis, more or less 99% this patient is going to turn up to be methylmalonic acidemia. We have done for her, of course, acyl carnitine profile and urine organic acid, and they were diagnostic of methylmalonic acidemia. Yes. Another, so this demonstrates, of course, this patient did not have zero enzyme level. Okay, she had some residual enzyme activity مما مكنها انها تعيش all this period of time before she got stroke or she was diagnosed. She has 8 years, and for the first time she has been diagnosed as a metabolic disorder اللي هي methylmalonic acidemia. On the other hand, we have a 9-month-old boy presented with the main complaint of marked failure to thrive, global developmental delay, and abnormal posturing. This abnormal posturing because he had dystonia. He was the first child of first-degree consanguineous parent. He had an eventful perinatal history. At day 15 after birth, he had refusal of feeding, had tachypnea, then became lethargic, and he was admitted to the NICU, to the NICU, received IV fluid and antibiotic, and diagnosed as what? As sepsis, and discharged. Okay? And this was the first, احنا قلنا sepsis, metabolic workup should be done hand in hand with the septic workup. Okay? Especially in neonatal period. The patient experienced recurrent episodes of tachypnea, lethargy, with recurrent hospital admission, but with no definitive diagnosis. He presented to us at the Neurometabolic Clinic, and this was a long time ago. كنا لسه بادئين Neurometabolic Clinic. Okay, so at 9 months he presented with, as you see, he had marked failure to thrive. He was in severe metabolic acidosis. He had extensive ketosis, severe psychomotor retardation. As you see, scissoring of the legs and dystonic movement of the hand. He was encephalopathic. He was encephalopathic. Extended metabolic screen demonstrated an abnormality in C3-C2 ratio, which is characteristic of either methylmalonic or propionic acidemia, and then urine organic acid profile demonstrated that he has an increased methylmalonic, so he has been diagnosed as methylmalonic acidemia. This patient was very late, his diagnosis was very late. We put him on the specific dietary management, but he got renal failure and he died during dialysis here in Abu Rish. This again is his brain MRI, T2 brain MRI, and demonstrating these two high signal intensity lesion in the globus pallidi. Okay, but this is transverse section, so the appearance is different than from the axial section. So what are methylmalonic acidemia and propionic acidemia? The offending amino acid are the valine and the isoleucine, as I demonstrated in the first big slide. Valine, isoleucine, threonine, and methionine. Okay, also propionic acid coming from the gut, because the bacteria of the gut produce propionic acid, as well as oat-chain fatty acid. These are converted into propional-CoA. And then propional-CoA, in the presence of propional-CoA carboxylase, is converted into methylmalonyl-CoA. If propional-CoA carboxylase is deficient, okay, or if I have also deficiency of biotin, because it is a biotin, it is activated by biotin, then we will get this toxic substance, the 3-hydroxypropionic acid, 3-methyl citrate, and propional carnitine. The propional carnitine is detected by the mass spectrometry, while the propionic acid and 3-methyl citrate are detected by means of the gas chromatography. And then downstream in the catabolic pathway, this propional-CoA is converted into methylmalonyl-CoA, and then methylmalonyl-CoA is converted into succinyl-CoA. But if we have defect in the methylmalonyl-CoA mutase, okay, and then this would result into methylmalonic acidemia. But unlike propionic acidemia is produced only by a single enzyme defect. But methylmalonic acidemia can be produced by several enzyme defects, because the methylmalonyl-CoA needs adenosyl cobalamin. He needs vitamin B12, different form of vitamin B12 to activate. Okay, so if we have only the methylmalonyl-CoA mutase deficiency, we will get methylmalonic acidemia. But if we get, for example, cobalamin C also deficiency, okay, we will get homocystinuria as well as methylmalonyl-CoA, because he is responsible for activation of the methylmalonyl-CoA mutase and also for the conversion of homocysteine into methionine. The overall incidence is 1 to 50,000 in case of isolated methylmalonic acidemia, but propionic acidemia is rare. It's from 1 to 100,000. In some population like Saudi Arabia, as I mentioned before, it could be up to 1 into 2,000 to 5,000 live births. The presentation of methylmalonic and propionic acidemia, they can have either an acute presentation or a chronic presentation. The acute presentation, if in the neonatal period, they are going to present with a neonatal sepsis-like picture, refusal of feeding, vomiting, etc. Or they can present in a more chronic form by episodes characterized by, as we have seen in the small boy, characterized by a recurrent attack of metabolic acidosis, vomiting, failure to thrive, etc. Concerning the CNS, they can present, of course, with an acute encephalopathy, seizure, or an abnormal movement if we have stroke in the basal ganglia. Or they can present simply by developmental delay and movement disorder. So any patient coming to you with movement disorder, whether it is a choreoacetosis, whether it is a dystonia, okay, and associated with global developmental delay, we should put the possibility of an organic acidemia. GIT, they can present with vomiting and difficulty. Hematological, this patient, the severe metabolic acidosis can result into depression of the bone marrow. So it is common to find in this patient neutropenia and even severe anemia. and sometimes thrombocytopenia. I have the patient whom I was treating with methylmalonic acidemia, and this patient had severe anemia لدرجه ان احنا افتكرنا ان there is something in the bone marrow, and he has done even bone marrow في الهيماتولوجي department, but his bone marrow was okay, and this was from the severe depression he is subjected to as a result of the metabolic acidosis. The propionic acidemia is known to have to be associated with cardiomyopathy or with cardiac problem, while methylmalonic acidemia is known to have the impact on renals. Patient can die out of renal failure. And this is in case of propionic acidemia, any patient diagnosed with propionic acidemia should have an echocardiography. They can present either with a hypertrophic cardiomyopathy, as you see, hypertrophic cardiomyopathy, or they can present with dilated cardiomyopathy. And sometimes propionic acidemia can present in adult يعني 20 و30 only by cardiomyopathy, by hypertrophic or dilated cardiomyopathy, without any other neurological manifestation and without metabolic acidosis. And this means that any patient presenting with cardiomyopathy should be also investigated for of unknown etiology, not due to hypertension, not due to congenital heart disease, should be investigated for a metabolic disorder. Like we have diagnosed several patients with organic acidemia, mevalonic acidemia. We have diagnosed patient with mevalonic acidemia. He was referred to us from the cardiology clinic because he had also global developmental delay, and we found that he has one of the mitochondrial disorder اسمها mevalonic acidemia. So this is very important. Another case of methylmalonic acidemia and homocystinuria. How do these patients present? This was an 8-month-old female. Main presentation: global developmental delay, visual failure, and anemia. The patient, first child, consanguineous parent, and the mother. The main complaint of the mother was severe failure to thrive, difficult feeding, and failure of acquisition of normal developmental milestone. In addition, that at the age of 4 months, the child should have should track the visual field. Okay, she noticed that there is no visual fixation and that there is no visual following movement. Okay, so we had also a problem in the eye. Clinical examination revealed weight was less than the 5th centile for age. She was microcephalic, she was pale, and she had nystagmoid movement. With global developmental delay. Her CBC revealed a megaloblastic anemia. Okay, any patient in whom the CBC revealed a megaloblastic anemia, you have to think about the possibility of homocystinuria. Okay, but this is a non-classic homocystinuria. Okay, megaloblastic anemia with hypersegmented neutrophil and mild thrombocytopenia. Fundus examination revealed a pigmentary retinopathy and retinal detachment, both pigmentary retinopathy and retinal detachment, and this was the cause of her visual failure and the cause of the surging nystagmoid movement she had. There was no seizure, and brain MRI revealed non-specific atrophic change. In view of the megaloblastic anemia and ocular manifestation, homocystinuria was suspected, and we have performed total plasma homocysteine in addition to amino acid and urine organic acid. Urine organic acid demonstrated methylmalonic acidemia, and the total plasma homocysteine demonstrates that our homocysteine is 100 and a normal had 15 until 15. So this was a combined methylmalonic acidemia and homocystinuria, but at this time we did not have the luxury of performing whole exome sequencing. ما كانش لسه whole exome sequencing. We started using it from من 2015 when we had a big project مع Centogene in Germany, and then we started to perform the whole exome sequencing. But before this, we was diagnosis was confirmed only by biochemical investigation. So what are the signs of methylmalonic acidemia and homocystinuria? They include failure to thrive, microcephaly, lethargy, seizures, etc. The hematological manifestation, as we have seen, in the form of megaloblastic anemia, Retinal degeneration as well as pigmental retinopathy can also add in the diagnosis. Sometimes patient with homocystinuria and methylmalonic acidemia can present with hemolytic uremic syndrome. Okay, and this is due to cobalamin C deficiency. And if they are not properly diagnosed, they will die, and all die عموما يعني. And those who survive the initial episode, of course, are left with severe neurological sequelae. There can be also some dermatological manifestation for patients with methylmalonic acidemia and homocystinuria, like erythema, superficial erosion, desquamation, hyperkeratosis. And all these skin manifestations are attributed usually to the restricted dietary restriction. Okay. So by this, we have finished the methylmalonic acidemia and the propionic acidemia. Okay. Several things we have to put in mind. First of all, the brain MRI. Brain MRI presenting with bilateral and symmetrical high signal intensity in the globus pallidi. This indicates, in the context of a patient coming with metabolic acidosis, first suspicious is methylmalonic acidemia. This is first of all. Every effort, like in glutaric aciduria, should be done in order to prevent the stroke, the basal ganglia stroke. Because once the basal ganglia is struck, so there is abnormal movement, and this is very difficult to be reversed. Okay.
تعملي سكرين شو طيب شو
أكبرها؟ أعمل إيه؟ أوكي. Maple syrup urine disease, as you see, maple syrup, this is this is maple syrup. المابل syrup ده طعمه حلو قوي وبيحطوه في كندا على البانكيكس والحاجات دي فايز نايس. بس ده لونه، وده اللي بيبقى لون اليورين، اليورين بتاعه اللي هو بيقولوا لون السكر المحروق. ايوه يا اوكي. maple syrup urine disease. طبعا maple syrup urine disease is a disorder resulting from a defective catabolism of the three main branched amino acids, the leucine, the isoleucine, and the valine. The first step in their degradation include a branched chain amino acid aminotransferase, which converts them into their corresponding keto acids. And this is a reversible reaction. Okay, يعني ماشية reaction ماشية في اتجاهين. But then these keto acids are converted to acetoacetate and acetyl-CoA in order to enter inside the Krebs cycle. Okay. And this is catalyzed by the branched chain keto acid dehydrogenase. So the defect is in the branched chain keto acid dehydrogenase. When they are defective, this results into increasing of the level of the three amino acids together with their keto acid. Keto acid are detected by urine organic acid, and the amino acid are detected in the amino acid profile we perform. The branched chain keto acid dehydrogenase is a complex, and it is formed of three units. It's formed of E1 and E2 and E3. The E1 and the E2, if we have defect in the E1 or in the E2, واحد اسمه decarboxylase and the other transacylase, then this could result into maple syrup urine disease. But if you have a defect in the E3 dehydrogenase, بنلاقي حاجه اسمها lipoamide dihydrolipoamide dehydrogenase. And dihydrolipoamide dehydrogenase is a different entity. Patient mainly in this dihydrolipoamide dehydrogenase can present with liver cell failure together with severe hypoglycemia. And unless you diagnose the patient, usually the patient dies. Okay, so it's different than in the clinical presentation. So let's see together this case scenario. This was a 10-day-old patient presenting to the ER with seizures and metabolic acidosis. Seizure and metabolic acidosis, we have to suspect that it is an inborn error of metabolism, mainly an organic aciduria. She was a full-term baby, first child of first-degree cousin. الفيرست child يا جماعه we have to concentrate عليه 100%. Why? Because this first child, if you miss the diagnosis, then there is يعني the mother, yes, can bring another child having the same, and we see in the clinical practice mother in whom she has 1, 2, 3 deaths, يعني children who came and die, and then before the fourth is being diagnosed, or before the father and mother are being diagnosed as having an autosomal recessive condition. So this is very important. Important to diagnose. Even if the child died, you have to take sample from the child and send it for genetic and send it for biochemical diagnosis. On admission, she received IV fluid, طبعا sodium bicarb, to correct the metabolic acidosis. She was mildly hypotonic with hepatomegaly, and the provisional diagnosis was sepsis versus inborn error of metabolism. But despite correction of the acid-base balance, the level of consciousness was very bad. Her sepsis screen was negative. Serum ammonia and lactate were moderately elevated, raising, of course, the suspicion of an underlying inborn error of metabolism. So we ordered amino acid and acylcarnitine profile and brain MRI. But while waiting, what we are going to give to the patient? If a patient, I am suspecting a patient with organic aciduria, and I sent my lab test, and I am waiting for the lab test, what I have to do for the patient? I have to give him L-carnitine, a very high dose, 300 milligram or 200 milligram, 200 to 300 milligram. I have to give him hydroxycobalamin, okay, because of the possibility of being methylmalonic acidemia. I have to give him biotin because of the possibility of being biotinidase or holocarboxylase, okay. So I have to give him this cocktail of vitamin, in addition to putting him on a low protein diet or cutting protein at least for 48 hours. This is the MRI of the patient. As you see, there is wide spread, it looks like a demyelination. Okay, there is hyper-intense, diffuse symmetrical white matter hyperintensity in the brain. This was as a result of resulting from brain edema. This was the amino acid profile of the patient. What you see here, you see that we have a very high leucine, isoleucine, 1575. The normal is 245, so it was more than 5 or 6 times high. Leucine alanine ratio, all the ratio were high. The valine was within normal range. So the patient was diagnosed as having maple syrup urine disease. He, because his level were very high, he was dialyzed. This patient was dialyzed, and when the level are above 1200, we have to dialyze the patient and to give him valine and isoleucine, and to cut the leucine because it is the most neurotoxic. What are the manifestations of classical maple syrup urine disease in untreated neonate? First of all, you could detect a maple syrup odor 12 hours after birth, but this is difficult. Detecting the odor, I think it is difficult. And then, of course, by an elevated plasma concentration of the branched chain amino acids, the leucine, the isoleucine, and the valine, patient can have ketonuria, irritability, poor feeding, and then sign of deepening encephalopathy. I want to tell you that maple syrup urine disease is the worst, is the worst inborn error of metabolism you can deal with, because it's very rapidly progressing. Within 2 or 3 days, the patient is comatose, he has brain edema, and the patient can die within the first 10 days. And even if you start him on treatment, after 10, he is left with severe neurological handicap. Okay, so unless this patient is diagnosed in the newborn screening, usually this patient have a very bad prognosis. نعم. Yes. 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 We have to start treatment even if we don't have the final diagnosis.
هو كده كده حد زي ده يا دكتور هيكون داخل السكريننج
نعم
كده كده عند النيونيت لو ما تصير يعني
Yes.
ده داخل ضمن البروجكت بتاع وزاره الصحه بتاع السكريننج
يس.
بس هو بيطلع النتيجه بعد قد ايه؟
المفروض النتيجه تطلع خلال 24 48 ساعه بالكثير، اللي هو اتليست الاكستندد ميتابوليك ستريم. الصحه ما بتعملش يورين اورجانيك اسيد بروفايل، اليورين اورجانيك احنا بنبعته بره اوكي فارماجين يعني، لكن الصحه بتعمل بس الاكستندد ميتابوليك ستريم اللي هو الامينو اسيد والاسايل كارنيتين بروفايل. اوكي and then اوكي this is another CT of patient with MSUD showing brain edema. Look here on the right side, you have the normal CT. There is the ventricles are quite obvious, and then there is differentiation between the white matter and the gray matter of the brain. Here there is blurring of the edges. There is no differentiation between white matter and gray matter. Even the ventricle are not apparent because the edema is compressing them. Okay, so this is an MSUD crisis, and you have to be very cautious during giving the fluid for this patient. You have to give him brain dehydrating measures in order to improve this transient period. It is very important to know that transient period of MSUD encephalopathy appear fully reversible, provided no global or focal ischemic brain damage occur. On the other hand, if the patient is submitted to prolonged amino acid imbalance, okay, meaning that he is taking a lot of leucine or the offending amino acid, in particular if they occur during the early year of brain development, then this would result into structural and functional neurological abnormality, of course, that have a long-term psychomotor consequences. Okay, so أنا يعني personally most patients of MSUD either died or these patients are left with some kind of neurological sequelae, and this is mostly because they are diagnosed late. There is a late diagnosis. Even if they are diagnosed at 10 days, this is considered late. I have lastly a patient, but this patient was diagnosed, he came to us after 1 month. 1 month because he had from day 2 or 3 he has refusal of feeding and he was discharged, etc. But nobody took care to perform for him an extended metabolic screen until the patient entered into a disturbed level of consciousness, and then he was like all investigation are done and he was diagnosed. We have several types of mapped syrup urine disease. اتفضلي دكتورة سعاد. Thank you. اوكي ان شاء الله دكتورة سعاد. So we have the classic mapped syrup urine disease that we saw together with the patient. We have intermediate and intermittent form. Okay, sometimes the patient can present intermittently with ataxia or with confusion, and therefore we said that any patient having any episodic manifestation بتتكرر, we have to perform for this patient an extended metabolic screen and urine organic acid profile. There is one entity in mapped syrup urine disease, which is thiamine responsive mapped syrup urine disease, and certain very small number of patients with mapped syrup urine disease can respond to thiamine, and therefore we give thiamine universally. يعني whenever we diagnose mapped syrup urine disease we give thiamine اللي هو vitamin B1.
لو في الاول لسه مش عندي سسبشن ان هو مصير اتعاملت معاه لانه بيجي
اوكي
هيفرق معايا في حاجه؟ هيفرق؟
لا طبعا كل كانت اصل لا
مش هيعمل اي حاجه خالص.
اصل انت كده ولا كده العيان لما هيجي لك انت هتستوب هتدي له اي في فلويد، فكده ولا كده هو يو دونت جيف هيم اني بروتين. دي اول حاجه، فده هيقلل الليفل اوف ليوسين. ثاني حاجه هتدي له مثلا مانيتول او هتديله لازكس اور وات ايفر عشان البرين اديما، فديس ويل امبروف هيز كونشس ليفل. يعني منع البروتين في حد ذاته وان احنا نديله برين ديهايدريشن ميجر دي في حد ذاتها ممكن تحسن الليفل اوف كونشسنس اوف ذا بيشنت. ان اديشن بقى لو عايز تديله الحاجات الثانيه الكارنيتين اتسترا. So we have a special formula اسمها branch chain amino acid free medical food. This medical formula does not have valine and isoleucine. So after 48 hours of giving this medical formula, we have to add valine powder لوحده and isoleucine. This is very important because valine and isoleucine help to consume leucine, يعني help the leucine to be used by the cell and therefore decrease its level in the blood. So it's very important a supplementation of valine and isoleucine. Of course, if the patient, if the patient presented to me, and I know that this patient has maple syrup urine disease, okay, and his level, for example, is 1,200. My first step is to give him, I can give him putyryl and give him the medical formula. I know now his diagnosis. So I can give the medical formula in order to cut the catabolic state. لأن هم بيجوا في catabolic state. I need an anabolic situation. So I can putyryl, give him the free medical formula and together with valine and isoleucine. Okay? And then خلال few hours, if the patient does not improve, then I have to dialyze him in order to give him, in order to يعني أخلصه من الtoxic level of leucine. This is a patient with maple syrup urine disease. He was put on free formula and he did not take the valine and isoleucine. In order to impress you how much these are essential amino acid and their deficiency in the body result into burn-like lesion in the skin. Okay, and therefore it's very important. The supplementation with valine and isoleucine is very important. And but when we give him the natural formula and we supplement him with leucine and with valine and isoleucine, then all these skin lesions disappear completely. There is something to remember that essential amino acid deficiency can just be dangerous as protein deficiency. زي ما احنا بنخاف ان احنا ندي اكسس بروتين للطفل يدخل في intoxication، برضو الديفكتيف of essential amino acid can be as dangerous. لان in these conditions the patient is going to be in a catabolic state. He is going to break down his muscle in order to obtain the required amino acid. And you are going to find that your patient is not improving. On the contrary, it is deteriorating. So you have to give a balance between the natural protein you give and the formula you give. Don't do too much restriction because this could be deleterious for the patient. Okay. You have still time? We continue or okay. The next organic acidemia is isovaleric acidemia. This was a 3-year-old female patient. Now you notice that several patients did not come in newborn period. One come at 8 years, the other come at 3 years also, and this patient is coming at 3-year-old. Presented with the main complaint of altered mental status and tachypnea. First child, the first degree cousin, okay? And she was observed to be delayed in the acquisition of her motor developmental milestone, where she walked at 2 years. Some patients, because they have residual enzyme activity, then they don't come with the overt metabolic acidosis except if they are stressed, okay? But they can come, for example, with delayed walking. Any patient who has delayed walking, this is not normal. We have to search why the delayed walking, why he has delayed walking, why he is not alert to the surrounding. We have to search for this. الحاجة البسيطة, just we have to put our mindset in any patient coming with global developmental delay, he has to perform an extended metabolic screen and urine organic acid profile, وده اضعف الايمان. in addition that ممكن نزود عليه total plasma homocysteine, ممكن نزود عليه very long chain fatty acid according to the result you got and according to your clinical suspicion. Okay, so this patient has been delayed and worked at 2 years and not diagnosed up till now. At 3 years, he experienced severe attack of gastroenteritis with severe vomiting. Of course, vomiting, nothing no food entering in the GIT, and so the patient entered in a catabolic state, and diarrhea associated with altered mental status. Of course, a normal gastroenteritis does not alter the mental status of the patient. So if you have a gastroenteritis with alteration in the mentality or confusion, you have to suspect that this could be an inborn error of metabolism. The metabolic workup revealed metabolic acidosis with high anion gap. The patient was hyperglycemic and was ketotic. And sometimes these patients are mistaken as having diabetes, yes, diabetes mellitus. The hyperglycemia occurred because of the stressful situation, and so all the hormone اللي بتعمل hyperglycemia بتspur out. We have done for her, of course, extended metabolic screen and urine organic acid profile. The screen, the acyl carnitine profile revealed increase in isovalerial glycine, and this was confirmed by urine organic acid profile, which indicate increase in the isovalerial glycine and 3-hydroxy isovaleric acid by gas chromatography. So this confirmed isovaleric acidemia. So this patient at 3 years of age has been diagnosed as isovaleric acidemia. Why? She could be diagnosed before coming into stressful situation. If just we had raised, if just we had we thought why this patient is delayed. ليه هي متأخرة؟ Okay? كل حاجة لها سبب. Everything has an underlying etiology. بس المهم الدكتور لازم يفكر quite well what is the underlying cause. ما تاخدوش الحاجات superficial علاج طبيعي وكل حاجة هتبقى الأمور تمام. Okay? So isovaleric acidemia, the offending amino acid in isovaleric acidemia is the leucine. Leucine is converted into isovaleryl CoA, and then isovaleryl CoA should be converted to beta-methylcrotonil CoA. If I have the enzyme here, which is the isovaleryl CoA dehydrogenase, and then isovaleryl CoA will accumulate and it will be transformed into isovaleric acid, or hydroxy isovaleric acid, and isovaleryl glycine, which will be detected in the urine organic acid profile. This is one of the first patients diagnosed as isovaleric acidemia in our neurometabolic in the neurometabolic clinic. He was macrocephalic and he was diagnosed at 4 or 5 years. He was diagnosed late, despite the fact that this patient undergone several several episodes of disturbance in the level of consciousness and was admitted several times at the different hospital, but he was not diagnosed except after all this time, of course, left with a neurological handicap and mental retardation and microcephaly. So isovaleric acidemia is one of the acidemia which is rewarding, and usually the patient is, unlike methylmalonic or propionic acidemia, usually if you diagnose the patient and give him proper treatment, they can have a very good intellectual ability. Okay, so this was the first organic acidemia recognized. أول ما اكتشفوا الأورجانيك acidemia اكتشفوا الأيزوفاليريك acidemia. The incidence is 1 for every 230,000. Early diagnosis and treatment with a protein-restricted diet, okay, supplementation of carnitine and glycine are effective in promoting normal development. So this is isovaleric. Now, because the glycine is lost in urine, فبيبقى عندهم hypoglycemia. So it requires that you replace it. وعلى فكره الانديفيدوال امينو اسيد ار بريزنت، هم مش بريزنت في مصر. يعني لو حبينا مثلا عايزين الفالين الايزوليوسين we have لا اما ندخل على امازون ونجيبهم، لا اما ندخل على سايت بتوع كمال الاجسام اللي هي الشركات اللي بتعمل الباودرز عشان كمال الاجسام اتسترا، but they are not present free. يعني you cannot go to the I'm sorry you cannot go to the pharmacy and tell them I need glycine or I need, but we can buy them. Okay. And then another entity is a multiple carboxylase deficiency. Okay, multiple carboxylase deficiency اللي هي زي البيتونيدase deficiency. They are two sides of the same coin. So this ward is 3 months old male boy presenting with usual presentation, tachypnea, encephalopathy, and recurrent vomiting. طب أنا هسألكوا, this patient came to you. What are the first investigation we are going to do for this patient? اي حد يقول لي. ده احنا توقعنا انه عنده عشان التكيبني، عشان الكوسم ريسبيريشن. هنعمله اي بي جي بس؟ هنعمله اي بي جي، صوديوم and potassium, blood glucose. You are going to do for him the whole profile. Even CK is one of the important markers that you have to do in any patient coming to ill. Okay? Not because of the catabolic state, because if you find a CK high, this might indicate a fatty acid oxidation defect or a mitochondrial defect. Usually they have CK more than 1,000. I mean, it could direct your attention to the possibility of the patient could come with rhabdomyolysis, okay, and renal shutdown, and you don't know what is the cause. And when you do the CK and you find it increased, so CK include it in your first blood glucose. Of course, ketone in urine is very important. All this ammonia, lactate, all these are urea and creatinine, the kidney function test, because the patient might come to you with renal failure or a diabetic ketoacidosis, for example. So you have to do all these basic laboratory investigation. This patient at 3 months, he got fever with upper respiratory tract infection, followed by refusal of feeding, vomiting, lethargy, and then progressive tachypnea and deterioration of the level of consciousness. His oxygen saturation was okay, but his blood gases demonstrated that by carb 5 and the pH was 7.2. So this patient had a metabolic acidosis. His sodium and potassium, and he had an anion gap more than 20. The anion gap was 27. So this was a metabolic acidosis with an increased anion gap. Patients also have lactic acidosis. Lactate and ammonia are very important, and ketone in urine. Clinical examination, the patient was hypotonic, minimal response. He received, of course, dextrose bicarb to correct his metabolic acidosis, but the patient was not responding to the correction of bicarb. And we were preparing this patient for what is if a patient with intractable metabolic acidosis, what is the next step to do? Is to perform dialysis. So this patient, because he was not responding, so he was prepared to dialysis. Okay, and then when the resident called us, we told him to give the patient the cocktail, including the biotin. Once he took the biotin, even biotin injection, you can give him oral suzerile, and both have the same effect. He gave him biotin, and once the patient received biotin, his metabolic acidosis started to be corrected, his level of consciousness improved, and the patient was saved from doing a dialysis, which is an invasive procedure. Okay. His urine organic acid profile demonstrated the key diagnostic biochemical marker of holocarboxylase deficiency. So multiple carboxylase deficiency present clinically as two distinct disorders, the holocarboxylase synthetase and the biotinidase deficiency. Patients usually present in the neonatal period or the first 6 to 11 months with overwhelming clinical manifestation. identical to other classic organic aciduria. يعني holocarboxylase is in any mean different from any organic acidemia. The patient present with tachypnea, metabolic acidosis, ketosis, disturbance in the level of consciousness. And during the metabolic decompensation, of course, there is massive ketosis, there is a high anion gap, ammonia may be increased or not. Very important to take care of the cutaneous manifestation. Most of these patients has cutaneous manifestation in the form of seborrheic dermatitis. You are going to find that around the eye, there is a color of redness around the eye. He might have some alopecia. It could be present, it could not. But the skin manifestation in the form of erythematous skin rash or an extensive napkin dermatitis or under the axilla or here in the neck, in the collar of the neck. All this and a differential diagnosis of acrodermatitis enteropathica or seborrheic dermatitis or even ichthyosis, together with the presence of varying degree of alopecia. So the holocarboxylase deficiency, autosomal recessive, as you know, and it results from biallelic pathogenic mutation in the holocarboxylase synthetase defect. This results into reduction in the holocarboxylase synthetase activity. I will show you, yes, this picture is more illustrative. Here we have the holocarboxylase synthetase. The holocarboxylase synthetase is very important because it have to bind. It binds first with biotin, okay? When biotin binds to the holocarboxylase transfers the biotin into the apocarboxylase. The apocarboxylase are 4 carboxylases, the propionyl carboxylase, the methylcrotonyl, etc. These apocarboxylases cannot be active except after binding with biotin. And who binds them with biotin? It is the holocarboxylase enzyme. After binding with biotin, they are transformed into active holocarboxylases, okay? And then they can help in the degradation or in the catabolism, in the metabolism of protein, lipid, and carbohydrate. Now, if the holocarboxylase is deficient, then this reaction cannot occur. And also, if the biotin is deficient, as a result of biotinidase deficiency, the same exactly occur because both of them are linked to each other. The metabolic hallmark of the disease is excretion of this key compound, methylcrotonyl glycine and hydroxyisovaleric acid. Also, the first clinical chemical clue may be the presence of very high lactic acids. All patients are treated with biotin. It's the hallmark of the treatment. Once you give biotin, you are going to, it is a magic. زي السحر. Once you give biotin, in case of biotinidase or in case of holocarboxylase, then the patient is going to respond and everything is going to ameliorate. But if the patient is diagnosed late, after, for example, having a neurosensory sensory hearing loss or after optic atrophy, then this will not be reversible. But if you diagnose your patient early and you give him the proper treatment, this would result into improvement of the patient. And we have that diagnosed several patients with mainly with biotinidase defect. And what is very important is that you tell the mother, whenever you are pregnant, you have to take biotin throughout your pregnancy. And whenever she delivered, and for this patient, we don't have to do a prenatal diagnosis or nothing. And we tell her, once your baby is delivered, the second baby is delivered, give him biotin from day one, okay? This patient is going to go all through very, very normal, okay? And then at our ease, we can take the sample and we can see if this patient has a biotinidase defect, so he will continue. If this patient does not have, then he can stop the biotin. But this is very important concerning the mother to give her biotin during pregnancy and concerning the newborn. On the other hand, also the response to biotin. You may give, we know that the usual dose is 10 milligram per kg, okay? But and we have here the biotin fort, اللي هو 5 milligram, I'm sorry, 10 milligram, not 10 milligram per kg, 10 milligram only. but certain patient does not respond to the 10 milligram. Okay, patient can respond to 20, 30, up till 200 milligram of biotin per day. Okay, because the response to the biotin is different. Usually, I give up to 30 milligram of biotin per day. I don't give now the small dose, I give the high dose. Okay? And this is a treatment. It's biotin starting from 10 milligram up to 100 milligram, like I said. Okay, we now the last episode in this lecture is the emergency treatment. And I think that we have discussed this emergency treatment with you last time. And we have said that first of all, for the first 48 hours, we are going to cut the protein. But if you know the diagnosis of your patient, you can give him the free formula. Okay? If you know the exact diagnosis, give him the free formula, but without any natural protein. If you don't know the diagnosis of your patient, then cut protein for 48 hours and give calorie in the form of glucose 10%, etc. And then please give this cocktail. This cocktail is includes the following. It includes hydroxycobalamin. Hydroxycobalamin, why? Because there is methylmalonic acidemia, there is a part who can respond to hydroxycobalamin. Biotin, because you don't know, you didn't diagnose your patient yet. Maybe it is a biotinidase defect or it is a holocarboxylase defect. So as you have said, that the biotin has saved the patient from dialysis. So we have to give biotin 10, 20, 30 milligram, it's okay. Thiamine also, because of what? What disease requires thiamine? MSUD. MSUD may be thiamine responsive. Riboflavin, what disease requires riboflavin? Glutaric aciduria, and also glutaric aciduria type 2. Okay. And carnitine, of course, carnitine is the mainstay. You can give up to 400 milligram per kg. Why? As I said, carnitine combined with the acid moiety and form a soluble complex which is easily excreted through the kidney, and therefore it debarrasses the body from the toxic compound. In addition, of course, that we give metronidazole. Why metronidazole? Because as we have said, that the bacteria of the gut produce propionic acidemia. And so when you give metronidazole, you decrease the amount of propionic and consequently the amount of methylmalonic acidemia given by the produced by the bacteria. Antibiotic, because usually the patient has an infection which precipitated the attack. If he has a hyperammonemic episode, then we give sodium benzoate and we can give L-arginine, and you have the full in the first lecture, and of course fluid and electrolyte. And at least if we have done all this and the patient is not improving, we can go to dialysis. Okay. No. Either metronidazole or neomycin. You don't give them. I finished with this. There is 2 quizzes سايبهم على on the presentation. If you will get, did you send for them the last presentation?
Oh, yes.
Okay. Did you have the presentation on the guideline? Yes. You are going to find 2 quizzes. One quiz is completely resolved, يعني أنا حلاه, والother quiz بقى I'm leaving to you to answer it. Okay. Do you have any question? يعني أي سؤال؟ دكتورة عايزة تقول حاجة. صح؟ عايزة تقولي حاجة؟ Okay. Okay, thank you very much. I wish that you يعني انكم استفدتوا من نعم. ده البيبر. يس. اوكي. ايوه بقى بعد كده ما حدش يشخص قدامك.